I wanted to simplify it a little bit. I know not everyone here is a bariatric surgeon. In surveys past, I've had hands or response system. Most people who are attendant here have seen bariatric complications. As Dr. Ellie mentioned, we're seeing fewer and fewer lap band complications. I think some of it may have been changing the early techniques, which may have had more slips and migrations and erosions, but also we're taking more and more of the bands out and conversions and revisions. So I think there are fewer and fewer people, but there's still hundreds of thousands of people that do have lap bands in place, and these are acute problems that you may want to see. I'll reinforce what was said earlier, that a port site infection is a lap band erosion until proven otherwise. And you need to do an endoscopy probably in all of those patients to make sure they don't have an infection before you just go a relatively simple operation. You can go ahead, David. So this is an example of 2 lap band removals. I have the fortune of having a second-year resident on my service most of the time, and this is a great operation for them. This takes their basic laparoscopy skills. My initiation, isn't that nice? I passed her the knife, is to start at the port site. And this can often be one of the more difficult parts of the operation. This patient has had some weight loss, but was having terrible reflux, dysphagia, despite removing all the fluid from the band. So this one's pretty straightforward, but these bands can be pretty deep. They are secured to the anterior rectus fascia in most situations if they've been done correctly. So you need to get down to the capsule, very similar to taking a vascular port out. You find the capsule, but these are sutured to the fascia underneath, and you'll see where we try and get all that suture material out just with some electrocautery to the port capsule, elevating it and pulling it out. There's a second kind. If you remember in my first talk, I talked about the realized band has a different type of port where there's a mechanical deployment of these little metal hooks. So you put it on the fascia, you turn a little mechanism, and these metal hooks go out. They don't have to be sutured down, so those can be a little bit hazardous. Once you elevate that port that looks different, you'll recognize it if you're taking one of those out. You see a different type of port. Be aware that there are these metal, probably 3 to 4 millimeter claw-like devices that hook into the fascia below. So again, we've identified the port and the capsule. Elevate that up and try not to take too much of the capsule off posteriorly. This can be fascia, and you can end up being in the rectus muscle very quickly depending on how people have secured